Done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So what we have here today is a middle-aged border collie who has a history of being hit by a car. Hit by a car and was acutely non-weight-bearing lame, but also incidentally had some pretty bad thoracic trauma as well. Had big pneumothorax. Had severe pulmonary contusions, having difficulty oxygenating, was managed at another emergency center for 2 or 3 days with chest tubes, etc., and was stabilized, and it came to us for repair of the fracture. And so it still has chest tubes in place, and we have repeated thoracic radiographs today, and the lungs still have some pulmonary contusions, but the pneumothorax is resolved. Not sure if it stopped leaking, but we can't see any pneumothorax on the radiographs, and we're not generating or producing any more air in the chest tube. It's interesting that traumatic pneumothorax often resolves more quickly than spontaneous pneumothorax. Spontaneous pneumothorax can take days or weeks to resolve, whereas traumatic, I think probably partly because of the presence of blood in the thoracic cavity, seals up the leaking lung pretty effectively. One thing that we do in some cases that have a spontaneous pneumothorax that doesn't stop bleeding on its own is we will do a blood patch, which means that we will inject whole fresh blood into the thorax. One study, 7 out of 8 cases, the pneumothorax or the air leak resolved. One thing that was interesting was that in 4 out of those 8 cases, they did develop an infection or pyothorax afterward, which may come from the exposure of pulmonary bacteria and then the presence of blood, which makes for a nice medium for growth of those bacteria. So I am making a craniolateral or dorsolateral approach to the radial shaft. You can feel the fracture right here. It's a minimally comminuted, kind of short oblique fracture. I'm trying to dissect between the muscle bellies down onto the radius. Apologize for not streaming for a few weeks. I have been on holiday. I turned 60 in May, and my wife and I both turned 60 in May, and so we took a little celebratory holiday together all over Europe. So we had a really nice time. I also went to the ECVS conference, so the European College of Vet Surgeons conference in Antwerp, Belgium. That was really good fun, learning as well as catching up with old friends. So that was good. Can I get another Metzenbaum scissor? This is pretty dull. We'll probably have to send this one off to get sharpened. So there's a question: in patients with a radius ulna fracture, do you plate the ulna as well? And for the most part, I do not. Just plating the radius appears to be more than enough. And I can't remember the last time I plated the ulna. And to my knowledge, I'm not aware of any failures, especially with locking plates and that sort of thing. They're just so biomechanically strong that I don't think that plating the ulna is generally considered necessary. So I can see my distal radial segment down here. Aaron, the other thing I'm going to need is some bone clamps. Bone clamps, yeah. So.
Do you want the kit? Because I think they have them in there.
I beg your pardon?
I think they have them in here.
Okay, we'll have a look at what we've. Okay, I'll have a look at what we've got. When we get settled in here, I'll ask Aaron to have a look at the questions on the live stream. Trying not to cut through this muscle. Is it flickering?
Yeah, it is.
So I am not going to Science Week. I'm working here, and I've been away for too long, away from my kids and my dog. And so I will be staying home. I do often go to Science Week, and I think it's really good quality CE for people that are kind of advanced general practitioners, residents, and specialists. So you can see the fracture right there, and there's a few little fissures extending downward. Just get a periosteo elevator. Freer is here. Let's clean things up a little bit. I couldn't see any significant fissures extending far down the radius, but I will, in light of what I can see grossly, I'm going to go back and just have another look at the radiographs. There are a few fissures extending down here. I'm doing my best not to handle those bone fragments at all. The kind of the open but do not touch approach. Let's just come back and look at the radiographs here. I don't really see any fissures extending downward. So now what we'll do is we'll get, can I get some smaller ratcheted reduction forceps, please? There are a couple of fissures right there. Can I get some 19 gauge cerclage wire and a cerclage kit, please? I'm just going to put a single cerclage wire on that fissure just to try to keep from splitting that out as I reduce this fracture. There's nothing worse than having a beautiful fracture like this that you think is just going to come together so nicely. There's another fragment on the back here. And then you try to reduce it and lever the distal fragment against the proximal fragment, and suddenly you break out a fissure, the whole thing falls apart, and you've got a much more challenging fracture than what you bargained for. So the safe thing to do is to put, you guys can see that little fissure. There's one right there and one right there. And then we've got a separate piece of bone that's loose on the back there, which I'm just going to leave. Now I'm going to use probably an 8-hole, so it's going to have to be crab claws.
Oh, crab claws, right?
Yeah. We're going to use an 8-hole 3-5 broad plate. This is a border collie, a very active dog, maybe a little bit overweight. And cerclage kit coming?
Yeah.
Thank you.
Do you want a pin bender, pin punch mallet?
I beg your pardon?
Pin bender, pin punch mallet?
No, won't need that. So just those ratcheted reduction forceps in the cyclage kit.
Okay. I don't think that's a fixed kit though. Yes, I've seen that.
Should have one, like with the wire twister and the pin cutter, but otherwise we can use just a little.
I have one 50 cutter, so I'll just open that.
Yep, and then a wire twister. Yep, thank you.